afternoon, everyone. I'd like to welcome you all to the second session of the third KU-UCI Joint Symposium 2020. My name is Jung-Kwon Yu. I'm a professor of ophthalmology and an assistant dean and researcher of KU College of Medicine. It is my great pleasure to host this session, the second day of the KU-UCI Symposium. Yesterday, we had 4 excellent lectures on the public health perspective of COVID-19. Today's meeting will move the focus to the clinical practice aspect of the COVID-19. Same as yesterday, we have 4 distinguished invited speakers from UCI and KU. I'm very sure that all the speakers will help us better understand the COVID-19 and update us on best possible best management. Each speaker will give a 20-minute talk. First, we're going to play all of the 4 pre-recorded lectures given by all the speakers. Then we'll have a 20-minute discussion at the end of this symposium. If you have any question or comment, you can send it through the chat box on the Zoom platform. Let me introduce the first speaker, Dr. Alpesh Amin. He's the professor of medicine and chairman of the Department of Medicine, School of Medicine, UCI. He also works as the executive director of hospitalist program, UCI. His academic distinctions include Master of American College of the Physicians, Senior Fellowship of the Society of Hospital Medicine, and America's Top Physicians by Consumers Research Council of America. His research interests include medical education, curriculum development, hospital medicine, and anticoagulation. The title of his talk today is COVID-19 Planning and Preparation, Risk Prediction, Clinical Trials, and Outcomes. Professor Amin, please run the video, please.
Hi, my name is Alpesh Amin. I'm the Thomas and Mary Cesario Chairman of the Department of Medicine, Professor of Medicine, Business, Nursing, Public Health, and Biomedical Engineering, and I'm founder and Executive Director of our Hospital Medicine program at the University of California, Irvine. Today, I'm going to talk about COVID-19, planning and preparation, risk prediction, clinical trials, and outcomes. Thank you for joining me today. The COVID-19 pandemic has been described as a watershed event in medical history of epic proportions, with this fast spreading pandemic stretching resources at healthcare institutions, practical considerations for management of a disease about which we are still learning has been a huge challenge. It is evident that the size and magnitude of COVID-19 pandemic was grossly underestimated and preparations were inadequate. As I talk about the preparation that health systems ended up going through, one of the major areas was that there was staffing shortages and the staffing domino effect. The American Hospital Association projected 4.8 million hospitalizations associated with coronavirus back in February 2020. There was an increased clinical care demand for tests and hospital staffing. 48% of acute care hospitals have no intensivists. There is less than 30,000 intensivists in the United States, and the model predicted that there would be 1 million patients that would need ventilatory support. Staffing issues were compounded by the fact that healthcare workers had fear and family pressures, and therefore were calling in sick. There was also self-quarantining by hospital workers after becoming ill or to care for family. And then issues were aggravated by traditional practice of staffing at 60% of patient census and adding staff as needed through float pools. The American Hospital Association requested from Congress, along with the American Nursing Association and the AMA, the American Medical Association, they recommended from congressional leaders that they needed financial and staffing support. They needed to train staff on implementation of pandemic preparedness. There was scarce supplies, including personal protective equipment, which we called PPE. There was ramping up of infection control and triage, training for healthcare professionals, and then training for and implementing expanded telemedicine and telehealth capabilities and covering the costs associated with higher staffing levels that led to increased costs. We also found that there was resource limitations and lack of validated information. You could see that there were limitations in bed capacity and ventilators and PPE. There was lack of treatment options, consistent information, and validated education. You could see on the graph on the right here that the number of journal articles and preprints kind of rose exponentially between February and March. Early hospitalizations were also projected to be an overestimate. The early Center for Disease Control suggested that for every COVID death, there were 11 patients that would be hospitalized. Then subsequent models dropped it down to 7 hospitalizations per death. And the current estimate was 4 hospitalizations per death. And Dr. Murray from the University of Washington stated that initially what was happening and probably what we saw in the CDC data is doctors were admitting anybody that they thought had COVID. With time, they started admitting only very sick people who needed oxygen and more aggressive care like mechanical ventilation. We also had the Center for Disease Control release the public health emergency preparedness and response capabilities in 2018. The drivers for this included evolution of public health preparedness guidance and resources, lessons learned from public health emergency responses. There were also findings from internal CDC reviews and assessments and feedback from public health preparedness practice community. And this slide shows the public health emergency preparedness. Back in 2001, the United States was faced with the World Trade Center and anthrax attacks, and they needed to prepare for health emergencies and create an infrastructure for that. And then after the 9/11 event, Congress funded the so-called PHEP program, which was Public Health Emergency Preparedness Program in 2002 to help build state and local public health emergency preparedness capacity. In 2011, there was a need for planning standards to accelerate and improve public health emergency management activities. And the CDC again published the Public Health Preparedness Capabilities, a national standard for state and local planning in 2011, and introduced a new framework to guide the PHEP cooperative agreement. And then in 2018, public health and emergency management work together help prepare for, respond to, recover from new and emerging threats to the nation. And this included updated capabilities and standards that were in 2018 to advance state, local, tribal, and territorial preparedness. But there was a whole process here of getting prepared. And this slide nicely shows a lot of the public health issues that have occurred. In 2001, we had the 9/11 and anthrax attacks. In 2002, we had the implementation of this PHEP program. 2005, Hurricanes Katrina and Rita hit. 2008, Hurricanes Gustav and Ike. In 2009, we had the influenza pandemic. 2010, we had the North Dakota flooding. 2011, we had development of the preparedness capabilities. 2012, Hurricanes Isaias and Sandy hit. 2015, the Ebola outbreak. 2016, the Zika virus outbreak. 2017, the California wildfires and Hurricanes Harvey, Irma, and Maria. And in 2018, we had capabilities update occurred again. So lots of things in the recent 2 decades that help shape this concept of being prepared. The 6 domains of preparedness include these 6: community resilience, incident management, information management, countermeasures and mitigation, surge management, and biosurveillance. And we had to, while helping to lead some of the COVID efforts here at the University of California, Irvine health system, we had to put some of these into practice in terms of surge management and information management and countermeasures and mitigation. So lots of work that we did to get ourselves prepared. But it was good to know that over the last 2 decades, there has been national and international work in helping communities and healthcare systems get prepared for social and public health issues that occur. Part of preparedness that also existed started out with symptom screening in the hospital, right? Because we learned that screening patients before they enter a facility can reduce exposure to other patients and healthcare personnel, help prevent the spread of disease within the facility, and help ensure PPE is used effectively. Many facilities utilize general screening steps that included advising patients to check their temperature at home before leaving their house or their dialysis sessions, advising them to put on face masks and cloth face covering before leaving the house, instructing patients that when they come to a healthcare facility and if they have fever or COVID symptoms, they should consider automated communication to remind patients about reporting symptoms. And if they have symptoms, call the healthcare provider before arriving, maybe stay in their car and let the nurse come out and visit with them at the car and assess their risk for having COVID. Ask all patients upon entry in the facility if they have fever or symptoms consistent with COVID-19. There were other things that were done in terms of symptom screening to prepare our institution. Placing a staff member at near all entrances or in a waiting room. If patients were now already wearing a face mask, then providing that, sending patients to appropriate waiting areas and having the waiting areas designed so that the seats were 6 feet apart or separating patients 6 feet apart. Here in California, we utilize the fact that we have pretty good weather, and so we had people standing or sitting outdoors and outside, and then obviously signs and posters and other things to guide our patients through some of this. We even utilize the technology to help with getting patients. We would let them sit in their cars and we would text them when we were ready to have them come in order to help control the process of social distancing and so forth. The other parts of surge planning is preparing the organization for a number of other, and our department and our physicians and nurses and other workforce or trainees. And we put together this document that had had a table of contents that included all of these different elements in terms of preparing our institution for COVID. And so you can see the table of contents, and they include everything from staffing to bed capacity, to subspecialty escalation processes, to educational material, and so forth. One of the things that we had to plan on early on was looking at, how do we model out how many COVID patients we're going to get, and how do we predict for it? So we decided to take an approach that looked at doubling time, and as we went, if doubling occurred, week by week, then that estimated the number of estimated COVID patients or rule out patients, number of estimated COVID patients with 7-day, 5-day, or 3-day doubling. And you could see if you were in 3-day doubling, it becomes pretty astronomical. Whereas if you were at 7-day doubling, it was much more manageable. And so this was part of the way that we started looking at this to try to plan and prepare our institution. Part of preparation is also appreciating your staff and thinking about wellness. We decided to take an approach to do a week on, week off model, thinking that if they're working for a week, then it's important that they take a break and minimize their exposure from COVID. It helps with their well-being, especially if you were in a surge event or surge situation. We looked at continuation of essential services in subspecialty areas. We knew that subspecialties like cardiology and nephrology and GI and palliative care and infectious disease and pulmonary would be a very important services to maintain in the hospital. It also was kind of interesting, right? Because we learned that, as COVID tended to go up in these hospitals, and for some reason, other patients didn't come in. And so we needed to make sure we had the appropriate staffing. And then we needed to think about backup pools like illness and emergency quarantining of your healthcare staff and doctors, and then increases in patient volume. We learned that we potentially need 40 additional attendings for inpatient wards if we hit a peak. We also wanted to be fair to our healthcare workers because we learned very quickly that certain folks were at risk for developing COVID, and we didn't want to put them in those positions, or in those situations. So we developed a scale-up approach. We had category 1, the physicians that were within 10 years of their latest training, of fellowship or residency, would be the first pool of doctors that we would call back in if we started going to a surge. Category 2 were providers or physicians, nurse practitioners, trainees who are greater than 10 years out of their latest training, but they had no comorbidities, and they would be the second group that we would call in. And then I oversee our Department of Medicine, which is the largest department in the university, and we have a couple hundred faculty, physicians. So we had to put them into category 1, 2, and 3. And category 3 were providers that were considered the higher risk. They were over 65. They may have had underlying comorbidities, and as listed here. And these were folks that we did not. We would not have them come. They would be the last pool of people we would have come in. So we went through surge planning. As you can see, we tend to have a capacity of about 134 patients on our medicine inpatient services or hospital medicine services. We built capacity to almost double that, to go to 240 patients. We also looked at our units, and at phase 4, surge level 4, we added an additional 140. We had a total of 149 telemetry beds, and we had a medical, surgical, pulse ox, and total beds that they had another 135 plus 20. So this started scaling up, and we looked at different places across the organization where we would put these patients in our institution. We also have in our medical ICU, we have a capacity of 24 patients on a regular day. We scaled up where we could have 132 patients in case a real surge occurred. And as you can see, we built a capacity for 230 beds and 230 vents if we needed to. And we found places across our organization to do that. The other part of our planning and preparation was we developed our own protocols for admission so we could control the front end of which patients we really needed to care for in the hospital, who we could care for at home. And so we developed algorithms, and this is our pre-surge algorithm. And then we had a different one in case a surge hit and how we were going to, where we might have had to make some tougher decisions about which patients we could accept because we'd be running into capacity issues. And then we had a third algorithm around heavy surge that we designed and created and put into play. And so a lot of innovation that we did during this time frame. The other thing that I'm really proud of is the work that we did called a vulnerable scoring system. Working with our Center on Artificial Intelligence, a center that I'm proud of having had some influence in developing when I served as interim chair of radiology. Working with my colleagues, Dr. Chow and Dr. Chang, we developed this vulnerable scoring system where we actually, the purpose and the goal was the rapid spread of coronavirus obviously revealed significant constraints in critical care capacity. And we wanted a way of predicting this disease severity because we needed to help our physicians say, hey, should this patient be admitted? Can they be discharged from the emergency department? If they're in the hospital, can they be discharged or do they need to stay an extra few days? What is the likelihood of the patient actually needing to go to the ICU or being ventilated? So we developed a very simple scoring system using our own patients at UC Irvine, and we kept adding patients into this and using AI technology to do this. And we looked at, we did training and we did external validation. We used our internal data and we got some external data from Emory and we put this into play. And so here's the UCI training performance, and our diagnostic performance was using this definition of a 30% score threshold, where the ability to identify patients who would require intensive care within 3 days, because you want to know that up front so you can do the right thing for the patient. So you could see our positive predictive value and our negative predictive value and our accuracy, numbers when we did UCI training performance through this. And then we did internal validation with our patients, and you could see our positive predictive value was 83%, but our negative predictive value is 100%. And then when we did external validation, we had really similar outcomes in terms of using Emory patients, Emory University patients, and we had 86% for the positive predictive value and 100% for negative predictive value. So we felt like we had a good tool here, and this is what the tool looks like, and it's made up of, it's got clinical data, physical exam data, routine lab data, and some evidence of severity screening, which is easily able to be put in, and then it runs the data, and we can. And we used a 30% cutoff that, anything above 30% was a higher likelihood that patient was at risk for going to the ICU within the next 3 days or being ventilated. And that gave us a sense of confidence in how to manage our patients. So this was the investigative team that put this together. And you could see from the various different disciplines, everything from medicine all the way to biological sciences, pathology, radiology, artificial intelligence, public health, nursing, computation, computer science, regulatory. We had a lot of doctors involved in this process. I want to touch bases briefly on clinical research, because this was also part of our process of managing COVID patients. And the very first thing was I put a clinical research team together, and it included myself along with our infectious disease and pulmonary division folks, faculty, and we had we broke this up into thinking about symptomatology, where obviously on onset you have fever and cough, and as you get more and more severe, these patients have dyspnea, and then hospitalization, potentially ICU admission and ventilation. And so as we started thinking about we brought on clinical trials that were either NIH funded or industry sponsored, but we have clinical trials on the outpatient side or non-hospitalized patients. You can see post-exposure COVID negative, COVID positive with mild disease. We have all these trials. On the inpatient side, we have mild to moderate, which are hospitalized, and then we have the severe patients that may need it because they go into ARDS or whatever. And so you could see we brought on a number of clinical trials very rapidly, and we were the first site to bring on the NIAID remdesivir trial in California, and we got that up and going in 13 days. So we were really proud of that. So these clinical trials, I think, made a big difference in terms of something that we could offer these patients. We had partnerships with federal and state agencies here at UCI, other academic medical institutions, and local and national biopharmaceutical companies who sponsored these clinical trials. And these clinical trials, we have trials in the area of oral treatment that affect that have these types of different, including investigator-initiated studies like the magnesium study that we're putting together. And then we had intravenous treatment trials that you can see here, the most famous obviously being the remdesivir, but you could see the various different types of trials, including monoclonal antibody and IVIG and so forth, antiviral treatment. And then we had others that you can see on this, including the convalescent plasma and so forth. So my colleague will later on talk about the clinical trials in more detail. I just wanted to give you a brief feel for it, because it's the partnership between our clinical care and our clinical preparedness, along with these clinical trials, that helped us achieve great success in managing the COVID patients. And you can see our enrollments were quite robust. The Act 1, Act 2, and 3 NIAID remdesivir trial. You could see this one, and then you could see the enrollments in some of our other clinical trials that I am sharing with you on the screen. Now, I would like to end with some provisional data, and I have to state that this is provisional. It's hot off the press, but this is what some of our outcomes look like. And as you can see here, you can see a nice distribution of hospitalized COVID-19 patients. It was quite interesting. In the March-April timeframe, where we were preparing, we didn't really get much of a spike. And then it kind of increased towards the end of, towards the middle of, beginning of June, end of May, beginning of June, through the month of June. We saw a mini spike, and then it came down, as you can see, through most of the summer, and now we're ramping back up again, in terms of our numbers. But we're really proud of some of our outcomes data here in terms of length of stay when we compare to Vizient, which is made up of academic medical centers, so it's our peers around the country. Our average length of stay index, we were the best in California, as you can see, with the length of stay index of 0.94. And look at the number of cases. We had the second largest cases in the United States, in the state of California, with the lowest length of stay index. In terms of national data in the United States, we are ranked in the 6th in the country for the time period of around March to November. Again, we're validating this data, but again, our numbers are quite robust and quite strong. So our efficiency was really good because of the way we designed our systems here at UC Irvine Health. And then in terms of mortality, our mortality rates, you could see we did really, really well in California, where our mortality index was 0.45, second only to UCSF, which was 0.41, and we were third as a best performer in the nation. And again, these numbers are getting validated. They go from April to September, excluding hospice patients. So we're really proud of the strong work work that we did and the outcomes they're showing it to provide this. You know, UC Irvine Health is the only academic medical center in the 6th largest county in America. So we feel a big responsibility to our community to support them and serve them. So I want to end with just some unanswered questions that I can see come up in the future as we continue to work on COVID-19. You know, for example, newly recognized childhood manifestations of coronavirus, or what's going to happen with the second wave of non-COVID-19, and what's going to happen with non-COVID-19 patients. You know, are they going to come in, or are they going to stay home, and how are we going to handle that? What's the return to normal like? Is virtual healthcare here to stay? And will viruses reemerge again, even past the fall and winter? Or will the vaccine that's around the corner in the next month or two make a big difference for us all? Dr. Kaplan from the Society of Critical Care Medicine said, one of the unanticipated casualties of the pandemic are the patients who don't have it. It will take a whole lot of work and coordinated effort to re-engage with those patients. So that's some of the work that we continue to keep working on as we move forward. So with that, I wish to thank you, and my email was on the beginning of this presentation. If I can be of any assistance at any point in time, please let me know. Thank you very much.
Professor Amin, thank you for your update on the current management of the COVID-19 in the United States. His talk also covered the clinical trials and recent outcomes. Let me introduce the second speaker, Professor Sujin Kim, who is sitting next to me. She's the professor of emergency medicine at KU College of Medicine. She's also the associate director of KU Simulation Center, College of Medicine KU. She graduated from the Korea University. She did her research fellowship at the Winter Institute for Simulation, Education, and Research at the University of Pittsburgh. Presently, she is the chairperson of the Treasury Committee of the Korean Society of Disaster Medicine. Her research interests includes resuscitation, ECPR, ECMO, ED management, disaster medical system, postgraduate continuing professional education, artificial intelligence-based modeling, hemodynamic monitoring. Today, she'll be talking about emergency planning and response to COVID-19 in KU Emergency Department, from a scene to a hospital. Please welcome Professor Kim.
Hello, my name is Sujin Kim in the Department of Emergency Medicine. This topic is about emergency disaster planning and response to COVID-19 in Korea University Emergency Department. Emerging infectious disease events tend to show a slow onset and long-lasting impact. For minimizing damage, we should focus on flattening the curve that healthcare system can cover the event within the maximum limit of resources. If the surge overshoots more than the maximum pre-incident capacity, the damage of lives can be maximized without the national and external support. So, it is important to analyze our hospital capacity and surge capacity. These are the components of a hospital emergency operation plan. I'm going to present focused on hospital surge capacity, triage, and treatment area. Let's take a look at Korea University hospital disaster preparedness during pre-incidental period. We have prepared the emergency operation plan from 2009. We have maintained and reinforced the networking with community hospitals, 119, public healthcare office, and so on. We have refined the hospital emergency operation planning through annually hazard vulnerability analysis and regularly disaster drills with various topics. And we have developed, updated the strategy for emergency and disaster response. We made the disaster response level in accordance with the National Crisis Alert Level for infectious disease event, apart from the multiple casualties event. The level of response was defined considering required facility and resources available, namely hospital capacity. The response level in COVID-19 event corresponds to level 4. Our emergency operation plan for infectious disease event has been prepared from pandemic influenza event in 2009 through several disaster drills. 2011, disaster drill for the pandemic event preparedness. 2013, MERS simulation drill for emerging infectious disease event preparedness. And we have regularly trained the ED medical staffs how to use PPE, decontamination from biochemical injuries disaster drill in 2014. 2015, the MERS coronavirus outbreak was actually happened in Korea. The outbreak of MERS coronavirus resulted in 180 confirmed cases and 36 deaths across 17 healthcare settings. This outbreak revealed our vulnerabilities for responding to emerging infectious disease event and gave several lessons to the healthcare providers and hospitals in Korea. KU Annam Hospital is located in the northeastern area of Seoul. The hospital has more than 10,000 beds with 83 ICU beds. Our center is the designated regional emergency medical center and disaster core hospital center. The annual number of ER patients is about 50,000. 23% of ER visits were admitted and 5% were admitted to the ICU. As Disaster Core Hospital Center, we are running the disaster medical assistant team on a 24-hour basis and disaster truck, an ambulance with negative pressure functionality. We have disaster stockpile such as a tent, PP with PAPR, and negative pressure portable chamber. We set up the medical gas system in the shelter of ER parking lot and cafeteria. We developed a GMAT workforce with periodically checking the stockpile and running disaster training programs for the healthcare providers. Our center has a separate zone for EID with 2 negative pressure isolation rooms and clinic area. We have 1 negative pressure isolation and 3 isolation rooms in the emergency zone. And we have a fever sensing detector in ER entrance and available medical gas system for 8 beds in the parking lot. From now on, I'm going to share the experience on KU response for COVID-19. This graph shows the lower number of confirmed cases of COVID-19 in Korea. There were 2 peaks of cases in mid-February and mid-August. We had meaningful confirmed cases immediately before each peak, and we responded flexibly and changed the strategy of response at each time. Phase 1 refers to the period until 29th confirmed case on February 15 under the Orange National Crisis Level of Korea Center for Disaster Control and Prevention. Phase 2 refers to the period from 29 case confirmation to second peak. KCDC raised the red National Crisis Alert level on February 23rd. Phase 3 refers to the period after second peak. Upper blue graph is about response of KCDC. Lower pink graph is about the response of KU Hospital. During phase 1, we did not have any evidence of community transmission in Korea. We had screened the suspected case through survey focused on the overseas traveling history, especially from China. We could conduct a COVID-19 test in a very limited suspected case from February 7th. On February 15th, 29th patient visited our center. He showed chest pain, new onset LBBB, and elevated cardiac enzyme without any fever or respiratory symptoms. He did not have any traveling contact history with the impacted patient. During evaluation for chest pain, pneumonia with a typical GGO pattern was shown in his chest X-ray and chest CT. And his COVID-19 test was positive. After this remarkable atypical 29th case, we changed the strategy of screening from survey screening based on epidemiologic link to screening based on X-ray imaging and atypical broad symptoms on ER arrival. We started to expand the COVID-19 test for all suspected patients under the broadened case criteria. Many emergency medical centers started chest X-ray screening before deciding on the allocation for isolation on ER arrival. Second peak wave was related with the religious group and assembly-related transmission, especially in Seongbuk-gu, Seoul. The cases of admitted patients transmitted from impacted family members or caregivers in several hospitals began to be reported. So, we expanded the COVID-19 test to all ER patients. During phase 1, our strategy is as follows. We set up the ED workflow and used EID zone for sequestration. And we separated the suspected patient flow, and we defined and updated the suspected case definition. We tried to detect the suspected case through survey based on traveling, contact history, and fever or respiratory symptoms. And we updated the survey checklist by reporting to be reported cases. We set a clear communication structure for sharing real-time information, role description, and ED workforce using online chatting and schematic visual ad. We identified the suspected case through checklist and carried the suspected patient in EID zone in level D wearing. Non-suspected patient took emergency care in safe zone. The patient must have received the screening twice, and suspected patient must be isolated in EID zone until the test result came out. The red line was about the suspected patient route. In phase 2, we changed strategy from early detection to minimizing damage. We set the first priority to care for critically ill patient under ED healthcare provider protection. We created a surge capacity such as triage, screening, and EID zone, and started the risk stratified approach to the zone area and PPE level. We also started chest X-ray screening on ER arrival and to expand the implementation of the COVID-19 test with a regular schedule, and to learn the cohort words for the admitted patient before result came out. For identification, we regularly updated and applied the broadened suspected case definition for survey screening. We maintained the crisis and emergency risk communication. We started the risk stratified approach due to lack of facility and supplies. The risk stratified approach was applied through the suspected case definition. We assigned the treatment zone and PPE level according to the risk level. Highly suspicious case was defined as the case with pneumonia or fever and respiratory symptom, or contact visiting history to frequently occurrence, or unable history taking condition. EID zone and level D protection for highly suspicious case. Fever zone and 5-type protection for the moderate risk patient with undifferentiated fever. Cold zone and 4-type protection for less suspicious case with differentiated fever. We identified the suspected cases through survey checklist and chest X-ray screening. For definite care and patient safety, before COVID-19 test result came out, highly suspicious, critically ill patient with pneumonia in EID zone admitted to the designated negative pressure room in ICU. Moderate suspicious, critically ill patient with fever in fever cold zone admitted to the cold general ward. We made the EID zone with 4 temporary negative pressure isolation room additionally, and the screening, test, allocation area, and counseling room in the parking lot. EID zone for highly suspicious cases. Fever zone for the patient with undifferentiated fever. Cold zone for the patient with differentiated fever. From phase 3, there could be a symptomatic infected patient in anywhere in ER. We started to conduct COVID-19 test for all ER patients, including non-suspected patient. We also raised the PPE level in all zones of ER. In survey, we added content with legal responsibility of intentional misleading information by patient and family member. After COVID-19 event starting, what have changed in our center? Red bar is about the monthly number of ER patients in last year. Green bar is about the ER patient number per month in this year. The total number of ER visits has been decreased, but the number of critically ill patients who needed admission care has been maintained. The length of stay in ER has been prolonged, especially in waiting time for screening and boarding time for admission. It became to be difficult to providing definite care for socio-economically vulnerable patients. This graph is about the daily number of COVID-19 tests and daily number of admitted patients. Red box is about the confirmed case in the ED. We conducted about 60 cases of COVID-19 tests daily, and 5 to 6 patients admitted to ICU and 22 patients admitted to general ward. We have built and performed the step-by-step strategy based on the ED leadership and competency in disaster medicine and ED management, considering the patient flow from input to output and training for ED medical staffs. If we try to prepare one step earlier with the leadership, we can minimize damage under the worst condition, and we can save more lives. I'd like to say deeply thanks to the ED doctors and nurses. Don't be afraid, do not hesitate, saving lives and saving hours. Thank you.
Thank you, Professor Soo-Jin Kim. She nicely shared her experience during the COVID pandemic. And next lecture will be given by Professor Bharat Chakravarti. He is currently the Vice Chair of the Research and Academic Affairs, Emergency Medicine at UCI. He graduated from Boston University Med School and earned his Master of Public Health at UCLA. His research interests include population health, mental health, substance abuse. He was a member of the Microburns Emergency Medicine Faculty of the Year 2015, Teaching Faculty of the Year Emergency Medicine Student Fellowship 2012, and Microburns Emergency Medicine Faculty of the Year 2008. The title of his talk today is When an Epidemic and a Pandemic Collide, Substance Use Disorder in the Setting of COVID-19. Please welcome Professor BC.
Okay, hello everybody. This is Dr. Bharat Chakravarti. I go by Dr. BC. I am an associate professor of emergency medicine and public health at the University of California, Irvine. My talk is When an Epidemic and Pandemic Collide, Substance Use Disorder in the Setting of COVID-19. I have no financial disclosures. Well, we've all faced this scenario where we have an overdose patient that we've seen in the field or in the emergency setting, and it is not a friendly sight Usually these patients are younger of age and they have their whole life ahead of them. Always brings us to wonder what led to this event. I'm an emergency physician. I see the downstream events of a lot of bad things that have happened over the years. And I always wondered what actually happened that could be preventable, or the courses that we could intervene previously. This also brings me to discuss that not all substance abuse is actually street drugs, quote unquote. These medications have been linked back to prescribing practices from physicians, and particularly in the Western healthcare system, prescribing pain pills has contributed to the opioid epidemic. We've had 3 different waves of opioid epidemics. The first being a rise in prescription opioid overdose deaths. That's what was prescribed in the late 90s. The second wave is a rise in heroin overdose deaths. And finally, you see the third wave here in synthetic opioids. And although we have made some headway in plateauing the heroin and prescribed opioid deaths, which we'll get into a little bit later, the synthetics, which are fentanyl and tramadol and others, have been increasing exponentially. So where did this all start? Well, this probably started with our own cultural phenomenon here in the United States and in many Western countries, which is physicians want to be able to treat their patients. They want to be able to do something, and that often means a pharmaceutical intervention, a drug, a medication to take at home. So when patients come in with pain, we want to treat their pain. It is what we do. It's often what is expected of us from the patient's standpoint. And I think so this cultural phenomenon has really taken root and has been contributing to our overprescribing practices and not prescribing pain pills judiciously. Well, there are other reasons why we can lay blame to the current epidemic, and that can result in looking back at the Joint Commission's result of making pain the 5th vital sign. This all occurred in kind of the late 90s, and what that said was it really focused on pain, and not only that, focused on patient outcomes and patient responses to how they were treated in the hospital setting and satisfaction scores. And so that really set a precedent in hospitals and other patient groups to focus on pain management and to make sure that that was treated appropriately. And I think that really set some of the spark and fire and ignited an epidemic. Furthermore, not to lessen the effects of pharmaceutical companies and the pharmaceutical industry. The pharmaceutical industry spent millions and millions of dollars in promoting their new pain medications. Not only that, they had unscrupulous, just terrible science that was promoted and actually published in scientific journals that had no belonging whatsoever in science. It couldn't even be called science, but somehow it made our way into our journals. That made our way into our lore and our practice patterns as physicians. So these all contributed to what we have right now, which is a public health epidemic. Americans have opioid use disorders in great quantity, 1.8 million. Not all of these are just due to street drugs. Many of these, almost half of them, are prescribed pain pills. The estimated cost is astronomical. We've had a number of increases in emergency department visits, and 2.1 million people in the U.S. over the age of 12 had opioid use disorder involving prescription opioids, heroin, or both. So it's not just one, it can be a combination, it can be both. There's always a discussion of whether there is some priming or substitution when it comes to prescribing pain pills and then substituting it with illicits, or are people just substituting their physiologic need for the opioid receptor? It's really unclear and probably a mixed bag most likely. We have a lot of morbidity and mortality, especially as it relates to infectious diseases like HIV and hepatitis C and hepatitis B, endocarditis, cellulitis, abscesses, you name it. This is particularly of interest because further down in this lecture, we will see how this epidemic relates to our current COVID-19 pandemic, another emerging and emergent infectious disease. Obviously, opioid-related inpatient hospitalizations have increased, and not to mention the number of incarcerations involving opioid use has also drastically increased. Another area which needs significant overhaul in the United States. A completely separate lecture is our criminal justice system and how it has been failing, especially as it relates to the mentally ill as well as those who have opioid use disorder or substance use disorder. I feel like there are better ways that we can tackle this. In fact, there are known better ways, and we are going to be working on those later. So what about measures to stymie the epidemic? Well, there's prevention. We want to really focus on fewer opioid starts, shorter durations. This really means getting to educate providers, educate patients upstream. There's management, alternatives to pain therapy. Not all pain equals opioids. Obviously, we can do NSAIDs, we can do acupuncture, we can do stretching, we can do weight loss, we can do nerve blocks. There's so many different modalities that are possible and just need to be promoted. It's not always pain equals a pill, and that we are learning very, very well. We're tapering higher doses of patients who are on opioids. We're tapering them down as necessary. And again, we are trying to limit the number of dual prescriptions, especially with opioids and sedatives. In terms of treatment, the one big thing that I really want to highlight is medication-assisted treatment. There are really good medications for opioid use disorder and for substance use disorder, and treating them and giving them that pharmacologic stability to be able to deal with their opioid use disorder is absolutely crucial. Stigma is a huge problem. So we might have a great treatment, we might know exactly how to treat the patients, but getting past asking those questions to our patients as providers is really important. Making sure that patients also are aware that it's okay. It's not a moral failing that you have opioid use disorder. It's not a moral failing that you have a substance use disorder. Let us help take care of you. And then finally, harm reduction and stopping really means naloxone, antidote. If you're going to use opioids, let's make sure we keep you alive so that at some point we can then make sure we can engage you when you are ready and get you to a better place, get you back to stability, making really good social ties with your family and friends, getting back to work, and being productive in society. Still yet is needle exchanges. Preventing infectious diseases is really important, whether that be the reduction of HIV transmission and hepatitis. It's absolutely essential also in reducing the risk for endocarditis, cellulitis, and abscesses. And then furthermore, there's even more controversial, if you will, or emerging ways to help with harm reduction, and those are supervised injection sites. We have done quite a bit in terms of reducing the number of opioid prescriptions, over 21% in just 1 year, and also increasing the number of naloxone prescriptions. So we know as healthcare providers, as public health professionals, how to deal with epidemics. And we are making a grasp. We have a long ways to go. We definitely know from this graph here, this is a study done by my team in particular, in looking at providers and their proclivity to actually prescribe naloxone to ED patients being discharged. The one thing that we like to do is save people. We love that adrenaline. So a patient who comes in who's cyanotic with pinpoint pupils, who's apneic, and we know they have the toxidrome of an opioid overdose. We give them naloxone, we save their life, we feel great about it. Well, we see here that over almost 100% of prescribing of the providers that we surveyed feel that naloxone is safe. But what we also noticed is when we asked them if they're likely to prescribe naloxone to patients that receive opioid prescriptions from an outpatient, that number goes down fairly drastically. And then further yet, in prescribing naloxone is not burdensome due to the time required counseling patients. About 60% found it burdensome to prescribe naloxone. So we feel confident and feel great about ourselves in saving someone's life who's ready to die, but then not giving them that same medication to go out and save themselves or their colleagues or their family members, and educating them to give naloxone to their family. Why is that? We have a ways to go, and this is all about education and culturally changing our mindset. And this can happen. Well, we have a lot of great medications, as we mentioned before. Methadone, a full agonist of the opioid receptor, buprenorphine, a partial agonist, and naltrexone. All of these are effective. Buprenorphine is particularly attractive right now, although it's been around for some time, in that it is a partial agonist. It reduces the cravings but doesn't cause respiratory depression. And it really helps with it acts quickly and it lasts a long time. In all of this, in California, in the state that I live in the United States, there is what was introduced as the California Bridge Program. Now, California has been reported to be the 7th largest economy in the world. So we can take California as a litmus test for what can be accomplished in the rest of the world. And the Bridge Program really focuses on screening and starting treatment at the acute setting, in the hospital, in the emergency department, and making sure that everyone who has opioid use disorders screened, that they're treated with pharmacologic agents such as buprenorphine, and then linked with services as an outpatient. This is highly, highly valuable and has proven to work in numerous settings. There's over 50 plus hospitals and growing in California alone, and really focusing on starting medications, saving lives, treating withdrawal, and linking them with long-term care. Really has revolutionized the way things have gone. Now, this slide really we've seen before, but what this focuses on is that synthetic opioids, and opioids is the substance use disorder du jour, and has the highest incidence. So in terms of having a pharmacologic effective therapy like buprenorphine, it really works for opioid use disorder. Now, there are other substance use disorders, as you can see, with psychostimulants and cocaine and methamphetamines and so on and so forth, but the majority of deaths have been with opioids. Again, acute care really matters. It's really the central setting. This graph I love. It just shows me that with medication-assisted treatment in patients who have opioid use disorder, their mortality rate, their standardized mortality ratio, almost comes back down to normal levels of the general population, where you see those who receive no treatment have a standardized mortality ratio of over 6. But with treatment, with MAT, it returns to almost normal. Well, we already talked a little bit about buprenorphine. This is not a lecture in pharmacology, but it is a partial agonist. It has a really high affinity to that mu receptor. Its onset of action is in 30 minutes. It can be given sublingually. You don't even have to inject it or find an IV, and it lasts for some time. Just an absolute gem of a medication. It's been around for a long time. It's been introduced in France, where they had a huge heroin epidemic decades ago, and worked extremely effectively in reducing heroin overdose deaths. It's been used in Baltimore in the United States and had the same effect, and most recently has been introduced with one of our colleagues that we look up to, Gail D'Onofrio in Yale, who've done some exquisite studies in initiating buprenorphine treatment in the emergency setting and reducing the number of overdose deaths, reducing the number of uses of illicit drugs, and remaining in treatment over a period of time. This is a graph that just shows a partial agonist versus a full agonist versus a complete antagonist in terms of its overall opioid effect. And here we see a ceiling effect. What buprenorphine really does is it makes people feel normal again. It brings people back to normalcy, and here normal is good. So when you're feeling bad from withdrawal, it kind of brings you back to feeling normal. If you have a high, it brings you back to feeling normal, and it's a strong push to normalcy, which is fantastic. Why does it work? Again, we already mentioned all of this. It's long acting. The emergency department visits can be shortened. People always feel good in terms of the patient care. You don't need to actually put an IV in, and so on and so forth. So everybody wins. The patient wins, the provider wins, the nurses win, and the healthcare system wins. Well, here's a study that I talked to you about before that was initiated in Yale, which really showed a significant benefit for those who received ED treatment for MAT in terms of standard of care. And among those dependent patients, the ED-initiated bup treatment significantly increased engagement in treatment and self-reportedly remained off of illicits. Here's another trial again that showed very similar linkage of care. And what are the next steps? Well, the next steps really are, let's make sure everyone has buprenorphine on formulary. Let's get our first responders involved. Let's fund this. Let's have substance use navigators who are kind of life coaches and case managers and social workers really engage in helping these patients. And let's link these folks up with outpatient clinics so that they have longitudinal care. We were making a fantastic stride in all of this, and then along came COVID. COVID-19 naturally took a lot of our resources away and our attention because it was a pandemic. People were dying. Well, let's not forget about other epidemics as it relates to pandemics, and the severity of these epidemics can get exacerbated by the mere fact that our focus and our energies are completely in a different direction. Of course, COVID-19 is what we need to focus on right now, but we have to make sure that the vulnerable population, the ones in our country who are infected with COVID-19, is the same population that are also at risk for substance use disorder. Now, we've seen an 18% increase in overdose deaths since COVID-19 started. This is really from an overdose detection mapping application, and this is reported in the New York Times. We've seen that in over 40 states, some serious evidence of increase in overdose deaths in substance use disorder, particularly with opioids. What does COVID-19 do for people with substance use disorders? Well, it does a lot. There is the social isolation, which can potentially lead to the mental health and increased deaths. It can lead to using drugs alone, where you don't have somebody who's next to you that can say, oh my gosh, this doesn't look right, they're looking blue, let me call 911, let me give them naloxone that I was trained to give and save this person, so that this patient can be engaged when they are ready for treatment and get them to longitudinal care. There's less emotional support. There's potentially less drug availability as resources and access to care goes down. We certainly can have less patients available for clinic appointments and for care. We have certainly seen treatment centers being disrupted, less access to primary care, to naloxone, and to MAT, or medications for opioid use disorder. COVID-19 risk and outcomes in patients with substance use disorders, and this is an analysis from an EHR record, really was retrospective and showed that in over 317,000 providers across 50 states that we have seen an increase in those patients who have COVID-19 and an increased mortality rate for those with substance use disorder. Here we see that opioid use disorder here has the most and highest risk association between substance use disorder and COVID-19 amongst all of the other substances. So these patients in particular are the most vulnerable patients. Again, we see some health disparities with African Americans and people of color really suffering the most and who are most at risk both for COVID-19 as well as for substance use disorder and in combination. So all the more reason to help curtail this pandemic and epidemic and making sure that we treat both at the same time. Well, what can we do to prevent all of this from getting worse? Well, we have barriers and we have some guidance. Let's remove buprenorphine prior authorization. Let's not have insurance companies control that. If a patient needs buprenorphine and they come to a doctor, let's not wait for the insurance company to authorize it, because we know that it's going to be harder and harder for patients to get to see their doctor during this pandemic, and let's get them the treatment that they need right then and there. Let's also remove any waivers for the data X waiver licensing. So in the United States, we need to take an 8-hour training in order to get an X waiver that allows us to prescribe buprenorphine. That is absolutely ridiculous, because right now I can prescribe morphine, I can prescribe fentanyl, I can prescribe hydrocodone, and I don't need an X waiver license. These are full agonists and not partial agonists, which is what buprenorphine is. So let's take this cultural, historical remnant and remove it from our laws. We are in a unique situation. We could do that. Let's remove same-day billing restrictions. Let's share information amongst patients to help them integrate into our healthcare. Let's reduce the stigma that we started reducing. Let's really make it part and parcel of what we do when patients arrive to the primary care setting and to a hospital. Let's make sure that they are welcome and we address them as people. Still yet, our federal funds, a lot of this has been diverted towards COVID-19 and the pandemic, and rightfully so, but let us ensure that we don't forget about this epidemic, because there, as you know, there will be another emerging infection, another pandemic, but we should make sure that we have systems in place that are going to really delve into dealing with all of patients' requirements and needs. Let's also talk to criminal justice facilities, offer opioid use disorder and treatment while they're incarcerated, and then really engage in the reentry population and the homeless population, and make sure that our most vulnerable populations are treated with compassion and given the tools to allow them to succeed in their health. And we can do that. Thank you very much. Again, this is Dr. Chakravarthy from the University of California, Irvine, from the Department of Emergency Medicine and in the School of Public Health. Cheers.
Thank you, Dr. Chakravarthy, for your wonderful lecture on substance use disorder and COVID-19. Well, the final lecture will be given by Professor Junyoung Song. He's a professor of infectious disease at Korea University. He's also the director of Department of Hospital Hygiene and Infection Control at KU-UCI Hospital. He graduated from Korea University. He spent a year at the Department of Pathology, University of Alabama at Birmingham, as a visiting scientist. Presently, he's also serving as the associate editor for 2 peer-reviewed journals, Clinical and Experimental Vaccine Research, and the Korean Journal of Healthcare associated infection control and prevention. His research interests include influenza, respiratory viral infection, pneumococcus, emerging infectious disease, and adult vaccination. Today, he will give his talk on the clinical spectrum and infection control of COVID-19. And please welcome Professor Song.
Good morning, everyone. I'm Junyoung Song. I'm an adult infectious disease specialist. In my presentation today, I'll talk about clinical spectrum and infection control of COVID-19 in South Korea. The first part is clinical spectrum of COVID-19, and then the infection control measures for COVID-19 will be presented at the level of each hospital and government of South Korea. Coronavirus is classified into 4 genus of alpha, beta, delta, and gamma. Among them, alpha and beta coronaviruses can cause human infection. Contrary to these common cold coronaviruses, 3 beta-derived coronaviruses such as SARS-CoV, MERS, and SARS-CoV-2 might cause severe infections, including pneumonia. SARS-CoV-2 is believed to have originated from the Hunan market in Wuhan, China. It's been presumed that the virus was transmitted to humans in the process of slaughtering a wild pangolin. SARS-CoV-2 is a small single-stranded RNA virus, similar in size to the influenza virus, and the virus is very prone to genetic mutation. SARS-CoV-2 binds to the ACE2 receptor by spike proteins on the surface of the viruses. Because ACE2 is distributed at highest density in the upper respiratory tract, the virus can be easily transmitted through respiratory droplets. And since ACE2 is distributed in heart, blood vessel, and kidney also, disseminated SARS-CoV-2 infection can develop in severe cases. Most COVID-19 cases were thought to have fever and respiratory symptoms, but according to a study that analyzed 3,000 Korean domestic confirmed cases, only 30 to 40% showed fever and characteristic respiratory symptoms. After 5-day incubation periods on average, diverse symptoms may develop. Initially, most of them are mild, but 30 to 40% have pneumonia, and some of them are rapidly worsen around 10 days. So, 14% require intensive care treatment and 5% are fatal. Therefore, even if the initial symptoms are mild, the elderly and chronically ill patients should be closely monitored for the possible aggravation during treatment. Looking at the pathogenesis of SARS-CoV-2 infection, in addition to the direct cytotoxic effect by SARS-CoV-2 virus, renin-angiotensin-aldosterone system, RAS dysregulation by ACE2 receptor depletion, SARS-CoV-2 virus-induced endothelial cell damage related thromboinflammation, and immune dysregulation are 3 main mechanisms for this progression by SARS-CoV-2 virus infection. One of the serious pulmonary complications seen in patients with COVID-19 is microclot, which causes thromboinflammation of lung microvessels. Clinical hypoxia is rather severe compared to the severity of pneumonia or pulmonary edema on chest X-ray, but pulmonary embolism is not seen on chest CT. Microclot is such an atypical ARDS type complication. Pulmonary endothelial damage and inflammation can cause multiple microvascular thrombosis of alveolar septal capillary, and pulsation defects can be confirmed on lung scans. For this reason, low molecular heparin is prophylactically used in the treatment of severe COVID-19 cases. Renal complications have also been reported in patients with COVID-19. SARS-CoV-2 virus can infect kidney proximal tubular cells with ACE2 receptors, so proteinuria and hematuria are very common renal manifestations. In particular, 20 or 40% of severe COVID-19 patients in the ICU are reported to develop acute renal failure within 1 or 2 weeks after hospitalization. Several factors are complexly involved in acute kidney injury in COVID-19 patients. The direct cytotoxic effect of SARS-CoV-2 virus on tubular epithelial cells and indirect factors such as RAS dysregulation, thromboinflammation, immune dysregulation, and rhabdomyolysis might contribute to the development of acute renal failure. Similar to renal complications, cardiovascular complications are caused by a combination of direct myocardial infection, immune dysregulation, and hemodynamic failure. Specifically, severe COVID-19 cases can be complicated by ischemic heart disease, arrhythmia, or heart failure with a 2-week interval from hospitalization. Looking at the current situation of COVID-19 pandemic in South Korea, most cases occurred in the age between 20s and 50s with high social activities, but 95% of the fatal cases were concentrated in the elderly, aged over 60 years. The overall fatality rate is estimated about 1.7%, much lower than the global average of 3%. This is case fatality data from the initial 4-month periods of COVID-19 pandemic. Compared to South Korea, Italy and China showed significantly higher case fatality rate, up to 6 times. Italy has the highest case fatality rate because the elder population is larger than Korea, and infection occurred mainly in the elder people. In China, the young age population is higher than that of Korea, but the COVID-19 cases were concentrated in the elder population as shown here. In addition to old age, chronic medical conditions are known as important risk factors for severe COVID-19. SARS or MERS has a high infection and fatality rate in healthy adults, whereas most fatal COVID-19 cases occurred in the elderly and chronically ill patients, similar to influenza. According to the early Chinese report, compared to healthy adults, the case fatality rate of COVID-19 was 9 times higher for diabetic patients, 13-fold higher for patients with cardiovascular disease, and 7-fold higher for patients with chronic lung disease. In summary, SARS-CoV-2 receptor ACE2 is widely distributed in human bodies across respiratory tract, heart, blood vessel, kidney, and intestine. In the development of severe COVID-19, RAS dysregulation, immune dysregulation, and thromboinflammation are 3 important mechanisms. The case fatal rate of COVID-19 is thought to be about 2%, but the fatal rate is much higher in the elderly and chronically ill patients. Therefore, it is very important to block the transmission of COVID-19 to high-risk groups, as can be seen from the contrasting results between South Korea and Italy. Now let's move on to the infection control strategies for COVID-19. 20 to 30% of COVID-19 cases are asymptomatic, and even in the symptomatic cases, the symptom onset is insidious, and the initial symptoms are very mild. However, they are highly contagious even at the early stage of infection. Moreover, unlike other respiratory viruses, the viral load of SARS-CoV-2 is very high in saliva during the early stage of infection, so the virus can easily spread out during conversation or eating together. Actually, there have been many cases of COVID-19 after brief conversation or eating. In the paper published in NHM in July, SARS-CoV-2 RT-PCR and viral culture were conducted serially over time before and after symptom onset. Interestingly, asymptomatic patients list high concentration of viruses, and pre-symptomatic patients also list high concentration viruses even 3 days prior to symptom onset. Therefore, the contact tracing was expanded to 2 or 3 days before the symptom onset. Even though SARS-CoV-2 gene fragments are detected for a long period, more than 3 weeks, on PCR tests, a viral virus is not cultured if more than 10 days have passed from symptom onset. The red circle means viable virus detection. After 10 days from symptom onset, viable virus was not detected anymore. MERS and COVID-19 is known to have similar incubation periods, about 5 or 6 days. However, there are significant differences in the viral shedding pattern and transmission dynamics. In case of MERS, viral shedding reaches a maximum level on the 7th day from symptom onset. At that time, the patient is the most contagious. In comparison, SARS-CoV-2 infection is already the most contagious at the time of symptom onset, making it very difficult to block the spread of COVID-19. SARS-CoV-2 has a high R-naught value of 2.5, which means high transmissible potential in the community. Compared to other novel viruses, SARS-CoV-2 has a shorter generation time and high cellular viral load, so it is very easy to spread during conversation and eating. In addition, symptom onset is ambiguous and all symptoms are mild. This is why patients unintentionally spread the virus to contact persons. Recently, many nosocomial COVID-19 cases occurred in a teaching hospital in the southern part of South Korea, causing the hospital to be closed and medical system was collapsed. Similar cases have been reported in many other countries as well, so it is very important to keep hospitals safe and to do their functions. During early COVID-19 pandemic, Korean government and each hospital made hospital preparedness plans. In the hospital level, education and training, universal mask wearing, inpatient monitoring were reinforced. Many hospitals in South Korea has been conducted a SARS-CoV-2 RT-PCR test for all inpatients irrespective of symptoms before admission. Like other hospitals in South Korea, we regularly educated medical staffs about infection control strategies and personal protective equipment, and made it mandatory to wear face masks inside the hospital. Hand hygiene and mask wearing are important for each patient or medical staff. There is no study conducted on COVID-19, but according to a study conducted on influenza viruses of a similar particle size, hand hygiene alone was able to prevent influenza infection by 26 to 38%. Moreover, mask wearing showed a statistically significant prevention against influenza-like release with 66% effectiveness. Although a well-designed study has not been conducted on COVID-19, the effectiveness of mask wearing can be confirmed indirectly through a reduction in the incidence of COVID-19 after the introduction of mask wearing. Indeed, in New York City, since the introduction of mandated mask wearing, it's shown a dramatic decrease in COVID-19 cases, unlike other regions of the United States. Environment control is also important because COVID-19 can spread through contaminated environments and formats. Since SARS-CoV-2 can survive for 4 hours in air, 24 hours on cardboard, 3 days on stainless or plastic material, and 4 days on glass material, ventilation and environment cleaning is important. It should be thoroughly disinfected by rubbing with an environment disinfectant with sodium hypochlorite or quaternary ammonium complex compounds. Based on the past experience of MERS epidemic in 2005, Korean government established several safe hospital strategies. First, hospital entrance was restricted and gate screening was strengthened. Second, 2 specialized clinics were operated at the outside of the main hospital building. one for patients with epidemiologic linkage with COVID-19, and another for febrile respiratory patients without epidemiologic linkage. In addition, pneumonia patients were preemptively isolated until negative confirmation of SARS-CoV-2 RT-PCR. As for the patients in the area of COVID-19 outbreak, telemedicine was introduced. As you can see, the body temperature at the entrance is checked with a fever detector, and febrile symptoms, respiratory symptoms, and contact history with COVID-19 patients are investigated using a smart device or a paper questionnaire. If fever, respiratory symptoms, or contact history with a COVID-19 patient is identified in the screening process, the patient will be treated at a fever respiratory clinic or COVID-19 clinic, and SARS-CoV-2 RT-PCR will be taken. I'm gonna summarize now. Some clinical manifestations, short generation time, and high salivary viral load are challenging problems in the infection control of COVID-19. Most South Korean hospitals have been operated safely without nosocomial outbreak. Universal masking, gate screening, specialized clinics, and preemptive isolation of pneumonia patients are important factors of successful infection control in South Korea. Thank you for your attention.
Thank you, Dr. Song. Many thanks to all the speakers. Now it's time for discussion. If there's any question, you can write your question or comment to add on the chat box on the Zoom platform. Professor Kim, do you have any questions?
Sujin Kim, Korea University. I think there are different directions for responding COVID-19 between USA and Korea. In Korea, I think we focused on the test and tracing for blocking the spread of COVID-19. It means that our healthcare system can cover this situation until now. But we are facing at a third wave from November, and so to balance the demand and supplies of resources, especially facility and steps for caring the critically ill patient, is very important. Important point now. And so, is there any the healthcare coalition or cooperation groups for coordinating to build a surge capacity in Orange County? My question is, any some healthcare cooperation group or leading groups to make surge capacity, and then also what is the role of the primary care physicians or the clinician in small hospitals in Orange County, because in Korea until now everything is controlled by the government, and then the government has the leadership. And so I'm wondering about the USA situation.
So Professor Amin, are you online?
Yeah. Can you hear me?
Yeah, you can hear
Oh,
very
okay.
clearly.
Thank you. Hi, everybody. Welcome. So, if I understand the question correctly, how is our system organized here in Orange County for the care of COVID patients, including primary care doctors and the overall care of the patients across the county? Is that the question?
Yeah, right. Especially in the critically ill patient, because
The critically ill patient. Yeah. So Orange County is the sixth largest county in America. It has a population of about 3.8 million people, and And we're in a unique place where we actually are surrounded by 4 other really large counties: LA County, San Bernardino, Riverside, and San Diego County. But Orange County, we don't have what we call a county hospital. So whereas other counties like LA County actually has a county hospital, we don't have one here. So the burden of care for whether it's COVID or any other types of patients or illness is kind of distributed amongst the population, amongst the care delivery systems across Orange County. One of the things we do have is, from an insurance standpoint, we have something called CalOptima, and CalOptima is a managed Medi-Cal insurance system, if you like. It is under the state and the county. It is for the patients that are underserved. They have something called Medi-Cal insurance, and it's managed in a much more kind of managed care approach. And so that population has actually, due to COVID and due to changes in employment and so forth, that population has grown to about 700 to 800,000 folks. So what that's somewhere on the order of maybe 1/5 of the county's population. And so they manage that group of patients in a way that will obviously streamline costs, but provide high quality care. And so they've developed contracts not only with UCI Health, but with various other organizations. We also have free clinics. We have a county clinic. We have other resources within the county. But the bulk of the care for these patients, if they have insurance, Medicare or some sort of what we call commercial insurance, then they're actually accessing their physicians through their own network that exists already. So the folks that are part of UCI Health are coming to UCI Health. If they have Kaiser insurance, they're going to Kaiser and other types of systems across the county. The primary care, there's been a lot of innovation in the area of how we take care of patients across the board. We have been actually looking at the role of telehealth and continuous monitoring, so we can move patients from that we maybe normally take care of in the hospital, and we would try to move them to care at home. We're looking at a program right now that I'm assessing with a number of other folks called Hospital to Home, where we might be able to actually manage patients at home as if they were hospitalized, with appropriate monitoring, appropriate nursing, under physician care and telehealth capabilities. So that is another kind of way we're doing it. In the critical care arena and in the hospital arena, we have designed a system, and we, along with other hospitals, are doing the same thing. But most 98% of our patients, these are internal medicine, and internal medicine subspecialty is really where the burden is sitting. And so the hospitalists, we have a very well-developed hospital medicine group or hospitalist group. As many of you know or may know, this is the fastest growing specialty in U.S. healthcare, and it's the second largest specialty. When I started in hospital medicine, I think there was about 20, and now there's 65,000 hospitalists in the country, and it's been the fastest growing specialty over the past 2 decades. And I had the fortunate opportunity to help write the core competencies for the field. So one of the things we have published and we've encouraged is that they provide system leadership and care for patients in a more population health. So we have a dedicated COVID team or teams, dedicated COVID units, where patients that need to be hospitalized are managed by that group of physicians. And then the ICU, we've done the same thing, where we have dedicated intensivists that manage the ICU patients. And then we have obviously all the consultants, and every hospital is, I think, set up in some similar way or some variation, but most of these patients are managed by hospitalists or intensivists, and then they're transitioned to the outpatient setting where we transition them to a primary care physician who will then continue with the care of these patients.
Thank you, Professor Amin. Well, there's a question from the floor. I will read the question for you. This is a question from Professor Yoonjung Cho, who is the professor of laboratory medicine at KU. Her question is, I'd like to ask a question regarding the use of COVID-19 antibody test only in your country. Here in Korea, the antibody test was not available until a week ago. Do the most insurance company reimburse the antibody test, or is it not covered by any insurance company but still testable?
Yeah, maybe I'll take that also. This is Dr. Amin. So yes, it is covered by insurance. Actually, we've been very lucky here. Medicare, which is so the Center for Medicare and Medicaid Services is a federal organization which pays for Medicare and Medi-Cal across the United States, and so they have been very they have loosened their requirements on payment and have also streamlined a lot of their processes on something that we call expanded use criteria. So antibody tests are actually they're covered by insurance companies, both by Medicare as well as by commercial insurance companies. And folks are getting the antibody. We've probably had the antibody test available for going on between 2 to 3 months, I would say, at this point in time. And it's very easy for us to actually now get the test. It's a simple order and a very simple blood test, and the turnaround time is within a day or two that where the results actually are available and come back. And so it's both funded as well as relatively easily available at most hospitals. Now the challenge for hospitals, though, I should say one thing is that, whether it's antigen testing or antibody testing, the bigger systems around the country have had access to it, to these testings, because either through philanthropy that has been given or the systems have bought equipment and machines to do these testing. But there are a number of I would say, smaller hospitals around the country that may not have the same accessibility to testing. And and partly that's because of enough equipment, enough supplies, enough resources at the hospital level. But, things are now becoming more and more available. And then we have third-party laboratory areas. An example of it would be called Quest. And Quest Laboratories, for example, will do antigen and antibody testing. So a primary care physician that might have their own practice, they might refer the patient to a laboratory like Quest, who will do the blood test. They'll bill the insurance company and then send the results back to the primary care physician.
Okay, thank you. Any other question? Well, if there's no further question, okay, please.
I have a question. Thanks all for the presentation. I am Jong-Ik Hwang. Dr. Kim, showed very interesting data about the ER visiting case. The ER visiting case has been decreased compared to last year. So it seemed to me in Korea, hospital is in our next door. So that means the accessibility is very good. So, but this year, the visiting rate is dramatically decreased. So, do you have any comment, Dr. Kim? Do you have any comment? And please tell me and tell us. And also in U.S., Dr. Amin or Dr. Chakravarti, do you have any, the situation? Please tell us the situation in U.S., especially in your hospital.
Okay, Professor Kim, please.
In Korea, we have a different healthcare insurance system, and our Korea healthcare system is based on the national universal insurance system. It means that every the accessibility to emergency room or in the big higher level hospital is very easy, and so until now even though our center is the designated regional medical center by the government, the patient with mild symptom tend to visit openly to the regional emergency medical center. But after the COVID-19 event, the patient with mild symptoms don't want to visit to emergency room anymore because they are very afraid of the transmitted from the infected patient in the big hospital, and so it is very in emergency room, the ED overcrowding is very international, globally problems, and so after COVID event, I think the ER patient input, ER patient flow, like the input, maybe change it, and so it is good for the emergency medical system. But we don't know yet. But I think that it is good way to good example for the controlling the patient patient input to emergency room. It's good. Is answer.
Yeah, and I don't know if you guys can hear me. I'm Dr. Chakravarthy. I'm here at home, but in the United States, especially right after the initial lockdown and quarantine occurred, we had a drastic restructuring and decrease in the number of emergency department visits, where not just at UC Irvine, but throughout the country, and specifically in our county, we had drastic decreases with people staying at home. That significantly affected how we decided to staff our emergency department, and the patient volume, as you may know, also equates to finances and operations. So that happened when the quarantine first was put in place in March, I believe. But that volume did come back, and as the state and the United States where cases, the number of cases had decreased, and I think we experienced some fatigue in safety measures, the patients did return to the hospital setting. Now we have the exact opposite problem. I just worked today in the emergency setting. We were holding almost 50 inpatients, many of those in the ICU and step-down unit in the emergency department. And that means, as you know, a backlog of patients needing to be being on diversion for critical care access for stroke and cardiac receiving center and even trauma patients. So it's a difficult situation, and I think it's challenging and balancing staying open for the community and diverting all necessary hospital events and procedures so that we can be prepared to receive that surge. So it's a balance, and I'm not sure there are much smarter people to make these difficult decisions.
Okay. Professor Amin, do you have any comment to add?
Yeah, just I think there was the question was, what's the burden right now in our institutions? We have today we have about 65 patients that are COVID positive in our hospital. We have somewhere plus minus 450 beds. And it's actually grown from about 30 patients 2 weeks ago to 65 now. About 1/4 of them, 15 to 20 of them are in the ICU. 3/4 of them are on the hospital medicine services, and the ones in the ICU, about half of them are ventilated, the other half are not.
I have a question to Professor Amin, and it's a similar question, but similar previous questions. And is there any change? Do you think that, or do you expect any change of healthcare system after COVID-19 event? For example,
I think there is going to be some interesting, and actually for the positive, I think there are going to be changes to the healthcare system. I think we've learned to work differently within the healthcare system. I think telehealth is going to be part of our approach to how we take care of patients. I think the ability to do more care of patients across the continuum and reach into do more continuous monitoring that might exist at home is going to be part of the process. I think things like artificial intelligence may help with risk prediction and predictive models to help us in healthcare. I think there have been some streamlined processes in terms of clinical trials and getting things through regulatory processes that may evolve and get better in terms of their streamlined processes. I think we've learned some newer data that, just from how we take care of patients, just even the concept of proning and the value of proning in ICU ventilated patients. We didn't really understand the value. And in this set of patients, this group of patients, there's been a relatively decent value in terms of proning and so forth. So I think there's a series of valuable changes that are going to occur, and it's going to help us think more innovatively. So I'm very excited about the positive opportunities that are going to occur out of this. Nobody likes to be in a pandemic, but I think we have to make the best of it.
Okay, Professor Amin, I have a couple of questions for you. Well, in your lecture, you presented that your novel prediction risk calculation is very predictive of, very sensitive to predict the severity of the COVID-19. Do you actually triage the patients based on your calculation? That is my first question. And another question is, among the variables listed on the calculation formula, BMI was a risk factor. I presume that probably high BMI is a risk factor, but I was wondering if a patient has a very low BMI, is it protective or is it also be a risk factor?
So the first one on the risk prediction tool, the VSS, it was wonderful that, in a lot credit to my colleagues, Dr. Chow and Chang for working with us to really help develop it, and our team to, kind of pull patients in and continue to work on the model. But so the places that we use it is in a few different places, and maybe Dr. Chakravarthy can also add from the emergency department. But we have applied it in the emergency department and on the floors and in the ICU. So there are 3 places that we see potential utilization. In the emergency department, it might help in terms of deciding whether a patient should be admitted, should they be admitted to the ICU or to the floor? Does it give another level of comfort that this patient probably is not that bad and might be able to be discharged. On the floors, it's really more about, if we check it, what's the chances of this patient going to the ICU and needing a ventilation? And it helps us, kind of helps us streamline the bed capacity issues that we might have to plan for. And then certainly in the ICU, when we're thinking about whether a patient can be taken off of a ventilator. Now, none of this we're still studying it, I should say. Our risk prediction on the several hundreds of patients that we have had has been valuable, and it seems to have occurred, but we haven't done a full, true randomized trial or anything on it because we just haven't had we kind of had to put it into play and test it as we were dealing, and then we had this rapid downturn of COVID patients, and now we're back on an upswing of it. So all of that has come into play, but we've been utilizing it, and we've seen certainly some value in the utilization of it. And then the other question that you asked, well, I'm sorry, I forgot it.
I was wondering if a very low BMI is a risk factor or not.
Yeah, so most of the literature talks about an elevated BMI being a risk factor for this, and that's why it's part of the risk prediction tool. Low BMI, I would not necessarily say it's protective for COVID-19, and I'm not sure whether we really know at this point in time whether it actually truly increases risk or not. But certainly the high BMI, and we've done, doing some health economics and outcomes research on a very large database of over 100,000 COVID patients. We have also found that, and we're publishing those results as we speak, but we've found that the BMI is actually correlative.
Thank you.
Okay, I have one more question. For Dr. Song, can you hear me?
Yeah.
Yeah. So you showed about you compared many virus about the generation time after infection. Especially the COVID-19, the generation time is just 0 day compared to others. But even other coronavirus has some 1 or 2 day generation time. But this is very special. So do you have any idea why this the COVID-19 has this the property? Yeah.
Actually, I don't know, but the SARS-CoV-2 virus has a high density of receptors in the upper respiratory tract. So, and the virus has a high concentration of viral load in saliva. So, I think that's why the virus is easily transmitted in the early period of infection.
Okay.
Okay, there's a question.
And I have one question for Dr. Amin.
Yes.
Yeah. Thank you for your good presentation. In South Korea has been well controlled the COVID-19 pandemic compared to other countries. However, as the winter season came, the cases of COVID-19, particularly critically ill cases, are dramatically increasing. So I wonder how the Orange County or UCI are planning to expand the ICU beds for severe COVID-19 patients at the situation of a sudden surge of COVID-19.
Yeah, that's a great question. Thank you for asking it. We've seen numbers as high as 50% of our patients in the critical care unit. But I think what has happened over the past 3 or 4 months that we, or I say 5, 6 to 8 months that we've been learning about this, we've learned through an iterative process and through the fact that we now have some therapeutic options, to be able to treat patients remdesivir or dexamethasone and so forth. There's kind of a twofold thing that's happening. The sickest of the sick are actually getting the hospitalization, right? The ones that are not that sick, that we can predict that they don't really need it, we're actually sending them home. So the burden that when we first started, everybody was getting hospitalized, right? And then, and now we're actually really truly streamlining the ones that absolutely need hospitalization. And so with that, the patients that are on the floors and in the ICU are actually pretty sick, and need to be in the hospital. The second thing is that we have actually also learned to do some innovative things. We have some of our long stayers that are in the ICU, we have created some partnerships with what we call an LTAC, which is long-term care facility. And they can take care of ventilators, they can take care of patients. So we can move patients from the ICU directly over there. And that has actually saved and helped us in terms of bed capacity and bed planning. The third thing is that when we first started 6-8 months ago, we were putting all the high flow nasal cannula patients in the ICU. Now we've learned that we can actually manage them on the floors or in the step down unit to help save some of our ICU beds. And our nurses are getting a bit more familiar with how to care for these patients, and we have really, really good, physicians, hospitalists, and intensivists that are really managing these. And that's why you're seeing the outcomes that we saw, the mortality rates and so forth. So the combination of the whole process is improving the outcomes has really done a great job.
Okay, thank you.
Okay,
thank you.
Any other question? Professor B, please. Please move the camera.
Yeah, very nice to be here. All talks are very fantastic and very informative to me. My name is Kim. I belong to anatomy department. I have a short question to third speakers of UCI, Dr. Chakravarthy. Yeah,
I think Dr. Chakravarthy stepped off the call. I think he's not on the call anymore.
Probably he got a call from the ER.
There is an email address.
Okay. Any other question?
Maybe you can email him the question.
If there's no further question from the audience, before we close this session, I'd like to invite Professor Abbott and Professor Bota to make a comment or a few words before we close this session. Professor Abbott, please.
Yes, I'll go ahead. Well, I just wanted to say it was a great series of talks today. And, the fact that we're overrunning with this discussion is basically illustrative of the amount of interest that's been generated by the talks from both Korea University and UC Irvine. I think it's incredible for these two countries that have been exposed to and handled this COVID-19 pandemic very differently. It's incredibly important to swap ideas, swap observations, swap experiences. And, that's what we all wanted to happen when we put this symposium together. So thanks again to all the speakers, the organizers at KU and UCI for a wonderful day of discussion and great talks again.
Thank you. Professor Bota?
Thank you for offering me the opportunity to close this evening's session. It was an amazing session. As a physician, I feel so proud of all our colleagues talking today, being frontline, both in the United States and in Korea. I think we have learned a lot from each other. I think we have learned a lot from the pandemic, and hopefully we'll be able to be better prepared should we ever encounter this event again in our life. All the knowledge that our physicians presented on both sides will be available. I know that many of you have made your presentations available online. I am very grateful for that, in the behalf of the colleagues that are not able to join us tonight, that we have had an excellent audience tonight. So I want to wish a very fruitful day to our colleagues in Korea, and to urge my colleagues here in the United States to rest for a few hours, as tomorrow it's another day of dealing with COVID-19.
Thank you, Dr. Bota. Well, I believe this second day session provided us with a new practical clinical information on the management of COVID-19 and also important lessons we learned from the COVID pandemic. On behalf of the Korea University, I'd like to give my sincere thanks to all the speakers for their excellent talks and productive comments, and the audience as well for joining this symposium. The third and fourth session of the symposium will be at online on the same hours, so tomorrow and the day after tomorrow. I hope you have enjoyed the rest of the symposium. Have a good one, everybody. Bye-bye.
Bye. Thank you. Bye.
수고했습니다.